Today, I'm presenting a case called the race for Rituximab, Granulomatosis with Polyangiitis presenting as orbital apex syndrome. Granulomatosis with Polyangiitis is a small to medium vessel vasculitis that affects the sinus tract, airway, and kidneys. Orbital or ocular involvement is present in nearly half of cases and is a common first presentation of GPA prior to progression to systemic disease. Orbital or ocular involvement can progress to cause visual loss if treatment is delayed. In this case, a 53-year-old male without any significant past medical history presents as an outpatient with the chief complaint of headache. He was clinically diagnosed with recurrent sinusitis for which he received several months of short courses of antibiotics and steroids. Eventually, he underwent sinus surgery with only partial relief of his symptoms. Postoperatively, the patient developed a cranial nerve 7 palsy that was thought to be a postoperative complication. This was followed by progressive ipsilateral hearing loss and contralateral vision loss. At a subsequent follow-up appointment, he was noted to have left orbital apex syndrome, characterized by cranial nerve 3 palsy with vision loss and proptosis, prompting admission for an expedited workup. On review of systems upon admission, he also noted 25-pound weight loss and night sweats over the previous 6 months. Admission physical exam was notable for a left afferent pupillary defect, no light perception or bleak to threat in the left eye, a lack of lymphadenopathy, a right upper and lower facial palsy, reduced hearing in the right ear, and a normal pulmonary exam. Admission laboratory studies were notable for normal CBC and CMP, elevated CRP to 82, elevated ESR at 130, and a normal urinalysis without any blood or protein. Admission imaging included a normal chest X-ray, an MRI brain that showed bilateral lacrimal duct masses with dural thickening and air cell opacification, which can be seen here on the slide. The patient was initiated on broad-spectrum antibiotics upon admission, and immunosuppressive treatment was deferred as the differential included infectious etiologies, lymphoproliferative etiologies, and granulomatous etiologies. On hospital day 3, P-ANCA and myeloperoxidase antibody returned as positive, and we had sufficient evidence for GPA to start pulse dose solumedrol. Before starting pulse dose steroids, the patient underwent biopsy of the lacrimal duct masses and of sinus tissue. Eventually, pathology returned to show vasculitis with granulomatous inflammation and necrosis consistent with GPA. The patient's symptoms improved minorly while he was admitted, and he was discharged on oral steroids and eventually received rituximab therapy as an outpatient without further progression of his disease. In this case, GPA was diagnosed in a patient with progressive cranial nerve palsies due to orbital involvement of his disease. Ocular or orbital involvement of GPA is common and occurs in nearly half of cases, and is associated with a large risk of morbidity given risk of vision loss. Prompt treatment is important to avoid vision loss, but the use of immunosuppressive agents should be deferred until lymphoproliferative and infectious etiologies can be effectively ruled out.